So let's go ahead and just dive in because, like Dr. Phillipson said, Dr. Peters, you have some interesting cases. I can go ahead and share the slides for you. Um,
Oh yeah, so I gave you these not are not all monogenic cases,
That's
but
okay.
I don't
that's
know the answers to or want input on. But by the way, just to go backward, can you give me a link so I can share this with my fellows? Because they don't get nearly enough education, if you ask me.
absolutely. I can get a link over to you, or if Lisa, if you don't mind sending her the link, that
Yep.
would be great too.
Sure, I'll email it to you right now, Dr. Peters.
Thank you.
All right.
Right, and I think we could even put it in the chat. Let's see.
Oh no, but if you do that, I'll never find it.
Oh, okay.
Not
But
make
so,
things hard for me. I
all
need
right.
it
Well,
on my email,
we
then I
don't.
give it to my fellows, then all is good.
Okay, we want to do that. So let me just, so what we've been doing with these, just to remind you, is so this is like our fourth session where we invite, people who send us cases from time to time to meet with some of us and discuss them and see. In some cases, it's a diagnostic problem. In some cases, it's just interesting. In other cases, it could be a therapeutic issue. And we have both. So now, because of David Panzier, we also have a Helmsley-funded study with the people at UCSF on autoimmune interesting things. So we're doing both. So if it's not type 1 or type 2, we're still very interested in other. And sometimes what happens is we end up referring to Radiant, which you've already done, I think. You sent a couple of cases to Radiant. So I remember doing that. So this is wonderful.
Just tell me whatever it is, because I see everything.
I know.
I mean, I see 25 patients a day in 2 different settings. So, in addition to all my other jobs.
Yes,
So,
and I see that many a week. So that's the difference right there.
all right. Well, so let's go through some of these because I want your input. So go back a slide because this is the second one. All right. So you want me to tell you what I think about this? Because these are cool. Like, I don't even know. So this guy's 40 and he got type 1 diabetes during the pandemic, but like really bad, severe DKA, pH of 6.8 in the ICU. This is type 1 diabetes, discharged on MDI. He has 0 family history of diabetes, and he is an identical twin. And the identical twin has no diabetes, nothing. I know this whole family by now. He was sure, and he had a lot of abdominal pain with the DKA, so he was sure. This is the kind of guy who's like wildly neurotic and reads everything. And he was sure that this was some sort of pancreatic cause for his diabetes, blah, blah, blah. And his wife, who at that point wasn't his wife, wanted to cure him with some no-fat vegan diet, which was like eating cardboard. And he didn't like this diet at all, but he went on it. And what happens is that he develops this unbelievable anxiety disorder about having diabetes. And he can't believe he has diabetes. Go to the next slide. He begins to need less and less insulin. And so over the last 5 years, he's ended up on almost no insulin, but he can't take no insulin because if he takes no basal insulin, his sugars go up. And if he gives mealtime insulin, rapid acting insulin, his sugars increase. And it's really the oddest thing I've ever seen in my life. And I say the reason your sugars increase is because you're eating more carbs, and that's why you're giving the mealtime insulin. But then he's done experiments and shown me that this is true. His C-peptide, which is non-fasting when I measure it, is between 0.6 and 2. And no type 2 medications work. He's been on everything. Nothing works but a tiny bit of basal insulin, which he gives or doesn't give. And give the next slide, because that's his last CGM. And he can't wear the CGM much because it makes him too anxious. And these are his tracings. So you can see that he still has broken beta cells. I mean, this isn't completely normal, but it's not terribly abnormal for someone who has type 1, but this isn't type 2. Now, the punchline to this is that he's been in the Radiant study. He got the first evaluation, and then he went to Denver, maybe, and had the whole clinical physical evaluation. But what is this? I don't know.
Well, all right. So almost every case you see is the strangest case you've ever seen that when you tell me about it. So I have to kind of weigh that in the balance. But so if it's a radiant case, then we have a whole lot of data. And that means also, he was considered whether, because you said he was antibody negative.
He's antibody negative, always had been no antibodies of any sort. And Radiant basically said the first phase, whatever the screening, it was all negative. So
right. So that means his antibodies were negative. And I imagine we could pull up his risk score, but I bet that was not high either. And so, from that point of view, either he doesn't have type 1 or he has basically a form of antibody negative type 1, but you would think that, the identical twin would get something at some point. So I don't know if Ro, do you want to, or Siri, do you want to say much about where we are so far, given that he's now, I don't know if he's gone through, he's actually been seen in Denver, actually. So they did stage 3 also.
Yeah, he did all the things and the clamps and whatever. And he really does have diabetes and it doesn't go away. And nothing that's type 2 treatment has ever worked. I gave him Prandin, I gave him sulfonylurea, it makes him too low. I can't, this is, and his A1C is like 6, it was between 6.5 and 6.9.
Well, look, it's significant that it made him too low, because that means nothing would happen. But let me just see if Ro or Siri has anything to add here.
Well, first I was going to clarify, yes, that he had went through the stage 3, but I think I don't have anything to add right now, but I am, we are certainly starting to amass hopefully a critical mass of patients like this in Radiant. And there is, a special interest group, interested in this exact, clinical presentation. So I'm always excited when you have like another patient like this, because I'm hoping again that we reach that mass to say something. I will also say I am really in my own kind of clinical, or I guess both of my clinical practice, but particularly wearing my hat in Radiant, happy to hear you say like you actually he proved to you that really the short acting was making it worse, because I remember hearing this a few times now in Radiant, and in my mind mostly dismissing it. So that'll change even just the way that I'm reviewing all the cases. But no, right now I'm stumped too.
So go ahead.
At this exact same 2-week period, I got 3 cases, new onset, same age, DKA from the same hospital, and it was weird because one of them ended up full antibody positive on insulin, on a pump from early on, one sort of in between, and then there's him. But what it shows to me is that just, that's the thing we keep teaching, is you can't tell us type 1 or not by whether they're in DKA, and all of them are, Caucasian, they're all lean, they don't look like type 2s, and they all presented with DKA and different types of diabetes.
Well, we might be able to look him up later. I mean, we can't share on the video if there were any Radiant results just yet, but the wheels are turning, and it's not, and it may be that we won't figure it out. I mean, I was asked yesterday to give someone an update on COVID and diabetes, and because you said this happened during COVID, that was how you introduced it, or it was before COVID?
I don't remember exactly.
So if it was 5 years ago, it was before COVID, but there is a huge literature about that. Our take is that we agree with you. He has a beta cell defect. The sulfonylureas, I think, are interesting, that they cause low blood sugar. And if it was a slam dunk, if he had a monogenic diabetes gene, we would know that already. He would have been rejected from Radiant if he had something we already know. So whatever this is potentially interesting. It's great that he has a twin. Often in Radiant, what we're doing is recruiting the healthy SIBs. So we're doing like subtraction sorts of things. So if there are variants, we're getting the SIBs involved. So all I can tell you right now is stay tuned. And the more folks you send to Radiant, the happier everyone is. So we'll keep doing it. But I think that's all.
He was diagnosed before COVID, because I went through a phase of wondering if COVID caused diabetes. It was well before that, but then the life went forward.
I'm sorry, just one comment is because I missed the very beginning, and I take it he presented with DKA and now has this picture where he's like barely has diabetes. and it reminds me of like ketosis prone kind of picture. And so my main question is, did he change his diet substantially?
Oh yeah.
He was not allowed any fat, and he became a vegan. This is a guy who ate French fries and burgers.
Oh,
He's also,
okay.
he's lean. He's not heavy, but he, you know, he was a typical, at that point, late 30s guy with, you know, bad habits and like going out with the guys and golfing, and I don't know, he owns some business and makes money, and he ate what he wanted.
Well, this is exactly the sort of individual we're looking for in Radiant, to see whether there's something we can come up with, and if there's a family and they're engaged. So, I mean, we'll get back to you. I think, you know, Radiant is working on it, so it'll grind through, and we'll see what else we can figure out. And it may be we won't be able to figure it out. That's also possible. But whatever it is interesting.
One more question.
Oh,
Yeah,
sorry.
Do you know what his birth weight was? Probably not. I mean,
No, it was like 6 pounds something, because he was, because I always ask, he was neither big nor little, but he was smaller
okay.
than usual because he was an identical twin. But it was like 6 pounds or 5 pounds, whatever. But it was a reasonable twin weight.
But you know, Siri, he's already had he's had whole genome sequencing through Radiant.
Yeah, but what wouldn't be uncovered by that is 6q24, which is just what kind of occurred to me briefly because of his picture. And that is something for us in Radiant, by the way, to kind of keep in mind too.
That's a good
anyway,
point.
I agree with you that it's a little bit of a mystery, and hopefully we'll figure it out eventually.
So, but it is so interesting that the identical twin doesn't have anything. So, all right, we're going to work on it. So, all right, so let's do the next case, and we're going to hold this one in our heads because there's like 4 more at least.
Oh yeah. Oh, I could have given you so many. Okay, this one, this is what I don't understand, and I see this all the time, is that this is a guy in my East LA clinic where I can't do genetic testing. And this guy he's now 48, but when he was diagnosed with type 1, he was 10 years old. And it was in Mexico, and I know nothing about the diagnosis. I do know that when he was diagnosed, he was a skinny, lean kid. And he was put on a insulin regimen, which I think in the beginning was not MDI, but became NDI once he got to this country. But he was the kind of person who had what was called brittle diabetes, right? His blood sugars were always up and down. And when we got him, his BMI was 34. He had stage 4 CKD and said he had a very strong family history of type 2 diabetes. At that point, his A1C was 8.2 on insulin, but he was going up, then down, then up, then down. And we were working on him to get him under control. So I didn't think that much of it here because it's CKD, it's somebody with, you know, diabetes, it's hard to control, it's had it for a very long time, blah, blah, blah. But then go to the next slide. Is then the reason he gets lost to follow-up is he goes away for 6 months. He goes to Mexico and he stops all of his insulin. He comes back and his A1C is 7.6, which is better than it was on insulin, which I think was making him worse. And his eGFR is 22. I measure his C-peptide, which is 4.6, and his antibodies are negative. And I couldn't get a detailed family history, but he doesn't fit type 2 because he had an early stage onset. I can't do genetic testing, and he's now on dialysis, and he's on a low dose of SG when his blood sugars are perfect. My question is, I think this is Modi. What kind of Modi? Because he has kidney disease. So is this Modi 5? I mean, am I missing? And so then I went back and I talked to the nephrologist to see if he had, you know, what kind of kidney failure he had. But this is in the county and they don't tell you what kind of kidney failure they have. He just had kidney failure and thought he was just a type 1 with CKD. But do you have any other thoughts than that?
Well, there's well, again, I don't know if Ro wants to go first, but yeah, we have many thoughts. So
I mean, I think the biggest thought is like, well, you know, when you next see him, can he spit into a tube so we can do the testing, and try to uncover, because I mean, I agree that sounds, very compelling for Modi. Then obviously if the panel were negative, then people qualify for Radiant. So those are my first initial thoughts. I think the HNF1 beta is harder to untangle without, being able to get the information that you were seeking. And as far as he doesn't have any structural abnormality, like any GU abnormalities, or, has he tried to conceive, those sort of things, pancreatitis, anything on the labs. I didn't want to say pancreatitis.
Did he have an ultrasound of the kidney that you can recall?
I looked through his chart and found one, which did not show. I mean, it just showed chronic diseased kidneys. It didn't show anything else.
And does he speak? I mean, if he's Spanish speaking, so here's the thought. So he would be great in Radiant. If he did get consented into Radiant, they would probably say get monogenic diabetes testing. So what we can do is do monogenic diabetes testing first through the registry. So he would have to sign a consent form, but we do have a consent form in Spanish. And so that's what Rose was saying. We send you the test tube basically, but he has the consent. So you could hand him the test tube if you see him, or have someone see him. He spits into the tube with saliva. Someone sends it back to us with the consent form, which you could do, like if someone could do a video thing with Tiana on the spot, we can get him consented. And we will then run, our 200 gene panel, see if anything shows up. If it does, we have a diagnosis. If it doesn't, he could go into Radiant and do that way. We also do the T1D risk score in the registry. So we would get a sense of whether, but this is clearly not type 1, right? So that's
it's not type
right.
1.
So we'll do it anyway, but it's not type 1. So that would be our approach, is we would do genetic testing as part of our research study. And the fact that he is from Mexico just is a win all the way around, because we need people who aren't like white women.
Well, we white women are fine, by the way. The problem with, I got to find him, but I think he's not. Do you take people who are not legal citizens?
Absolutely. There's no requirement for citizenship,
because they get scared about forms.
Well, and so that's part of what we try to do. So Rhoda, you want to address that?
So I was just going to say, like, for both studies, that is not an issue, and there isn't anything that we're going to collect that would, ask those questions. And certainly we can also address those concerns in the consent process. And I think if he were willing to move forward with the registry first, we could mention Radiant at that time and just make those same assurances. But yeah, it doesn't. There's nothing that takes any sort of documentation that here the reimbursement. That you're right, the tax purposes. I guess that would be the one thing. So we will have to think about a workaround for that. But we can also start. Lisa, please remind me when we for R&R, for our next R&R meeting. I'm gonna try to capture it right now too. To think through that as actually a potential barrier for participation. But the short answer is that's not going to be an issue, but we will figure out the reimbursement if we get to the Radiant step.
Yeah, let me know, because I've got a bunch of patients like this. What I don't understand is why so many of them get renal failure, but it's because I just don't get it. And I have patients with retinopathy. I think he has retinopathy, but I don't understand why. But regardless, what do I know?
Well, you come on now. You know a lot, and
I'm teasing, but I don't
understand. But I don't want my guys to get the wrong idea. I mean, you see more people than almost anybody. So, but I think there's lots of reasons he could have renal failure, right? I mean, just seriously. I mean, he had when you saw him, his A1C was 8. Presumably, it was higher than that since he was 10. How old is he now?
50.
So, so he's had diabetes on and off for 40 years, regardless, with this strong family history. I think he comes by kidney failure, righteously. You didn't mention his blood pressure so much, but maybe it's a combination situation. And what about his children? You didn't mention does he have children?
So if they're my patients, like the first patient, I know neurotically every detail about them. When they're seen in this clinic, they're the fellows patients, and the fellows tell me their stories, but not to the same detail. Right. Like I always know the birth weight. I know all that stuff, but I can always find them and go backward. He might have died, but I'm gonna have to look because my patients in that clinic don't tend to live beyond 50. but let me check.
Well, if he's still alive, we can, this is what we can do with our research funding. And I can't think of a better purpose than to go ahead and get sequencing and figure out what we can.
Well, and I have others, like I said, and they're almost all non-white people who I think have MODY. I mean, who are different. They're not the classic, because our clinic gets these that fall out of the normal treatment paradigm.
I mean, there's something also very interesting about specifically Mexican families. I mean, some have indigenous ancestry. I have, just off the top of my head, one of my close friends has 10 sibs or 11 sibs, and 9 of them have diabetes, and only 7 of them are obese. So even the ones that are non-obese have diabetes, and there seems to be an element of insulin resistance. So they have relatively high C-peptides. Some of them are very young. I mean, if this guy had, a large dose of whatever it is everyone else has, then yeah, you could have onset at age, at age 10, whatever it was. But that's not good. And then the renal failure. So yeah, if you can find out more, and if he's still alive and willing to spit into a tube, we'll put him on the DNA machine.
Cool. All right, next case. This is a whole different kind of case. All right, this one's, I have only a partial answer to, but this is a different kind of answer, you'll see. This is a 58-year-old woman, I think that's when I first saw her, she's now in her 60s, who had type 2 diabetes, and she wasn't responding to non-insulin therapy. She's got a BMI of 40, and so you look at her and she's obviously a large woman, but she had Hashimoto's. She has no family history of diabetes. So I checked her A1C, which was elevated, C-peptide 0.4 with a glucose of 210, and positive all antibodies. So this is an obese white female, but everybody said she was type 2, and she's not. So go to the next slide. You think this would be simple, but nothing in my life is simple. Once I started her on insulin, she started to have really bizarre symptoms that seemed almost, but not quite, allergic. And I sent her to an allergist, and it turns out that she's allergic to glycerol, which is an excipient that's present in all forms of insulin, both long-acting and short-acting. And so I had her desensitized to glycerol. But it also means that I can't go above a certain dose of insulin because her symptoms get worse. And so I started taking, because there had something to do with the concentration of the glycerol, and long-acting insulin just does her in. And so I take U500 and I dilute it down with saline, which doesn't have glycerol in it. And she takes 1 to 2 units. That's why I have to dilute it in part, because she's getting so little, U500, and she takes it 4 times a day at 4 a.m., 9 a.m., noon. Well, she takes it 5 times a day, 4 a.m., 9 a.m., noon, 6 p.m. in bedtime, because I can't have her on long-acting insulin. And each dose is 1 to 2 units of U500, dilute U500, and her total daily insulin dose is 0.2 units per kilogram per day. Because she's not on big doses of insulin at all. She's on very small doses because she's got type 1, even though she's morbidly obese. Go to the next slide. And if you go to this slide, this shows you her blood sugars. And she does an amazing job with that dilute U500. And she just gives it 5 times a day. But look, she's 89% in target range. So what I want to know is, do you know of any kind of insulin that doesn't have the excipient of glycerol in it? And I searched far and wide, and I can't find any. So I have to, she has to wake up in the middle of the night to give herself a dose of insulin. But there are these teeny tiny doses of U500, this dilute U500. So I'm just pointing out, this is what I had to do. And would anybody have done anything different? She doesn't respond to any non-diabetes, any type 2 meds, because she's a type 1.
Well, so from a different point of view, the question is that how interesting is it? So from the point of view of genetics of immunology, so she has type 1 diabetes, she has hypothyroidism, she has allergies to other substances. So the study that's funded by Helmsley, we have with UCSF, this might be of interest to see whether this is anything other than, HLA related type 1. So if she had a family history, of autoimmunity, that would help us enroll her in that study. But even having 3 autoimmunes or 2 autoimmune diseases and 1 allergy, that would be enough. We could sequence her on that basis and see if there's anything. So that's possibly in the background. I don't know of anything. I mean, the person to ask if there's some other way to do this would possibly be Mike Weiss who's now at IU. So he has a company, Thermalin, which is making new insulins that are thermostable. And if there was another approach to making insulin, he might know. We also have one of our friends, Karen Sylvester Sykes, is here in Chicago, based in Chicago. She's the worldwide Novo leader, which I don't know if you know her. She's the worldwide Novo leader for the ICODEC project.
Oh yeah.
And I don't know whether it's possible to get a compassionate formulation of ICODEC insulin that would work for this lady.
Interesting. Her allergist wouldn't let me use inhaled insulin. I really thought Afrezza might help her, but for some reason the allergist thinks that I'll kill her.
Wait, why? Because she has asthma?
No, because she's allergic to glycerol.
Oh, but is there glycerol in Afrezza? I don't know that.
No, but the allergist was just too everyone gets their fixed idea. She's allergic to insulin. I'm like, no, she's allergic to the excipient. She's not allergic to insulin.
Well, I love the idea of Afrezza. I mean, bring her into the clinic, get some epi and an IV drip, and see if she can take a joke.
Sweetheart, I'll have her get up in the middle of the night and give this before I'm going to do that. Trust me, I do not want to get in trouble.
Well, then, so maybe we're barking up the wrong tree. If he won't let her take an insulin that doesn't have glycerol and inhaled, then why would he let her try another insulin preparation that didn't have glycerol? He would get confused.
Well, A, it's a she.
Or whatever.
So, and I'm just teasing you. Second of all, I think that she would let me do it if it was insulin. She just had this thing. If you stick something in the lung to somebody who has allergies, you'll cause them to die.
Oh.
It's just one of those beliefs people have.
All right.
I have a question. So how much, so that UCSF study, will you send me the inclusion criteria? Because maybe I can go be in it. Do I have to have diabetes to be in it?
I actually thought about that. I mean, it is ostensibly diabetes. The idea is diabetes plus, but it's our study, so we're making it up as we go along. Basically, if you want to be sequenced under that basis, we could do that.
Because I have stage 2 type 1, because I go up, my OGTT is abnormal. Mm-hmm. And I have all the antibodies positive, and I have Hashimoto's, and I have terrible allergies, and I anaphylax to things.
We are recording this, by the way. So
I have no personal privacy. I have no boundaries.
Right. Dr. Peters has no boundaries. So,
but anyway, and my grandmother had Hashimoto's. There's a family history. I'm just
you're in. So we'll send you. It's the same link for our monogenic diabetes. It's the same consent form. We want to send you to patient 1, and you spit in the tube, and we'll since I guess you're the doctor, so we can share the report with you.
But by the way, I believe that, obviously I'm not concerned with personal issues, but if people like us, like me, and willing to share my antibodies, I think people should be sharing their antibodies so we can have discussions about antibodies, so we can see who needs what treatment and should be in what study. So I mean, one of
the conversations we're having with Mike, with Mark Anderson and Mike German is one of their colleagues has an interesting phage display assay, which you put your serum in there, and at least theoretically you can detect antibodies to all sorts of antigens, because they have peptides for all the human proteins. So that is something that they're looking at, and we haven't done any of our patients with polyautoimmunity yet, but so in principle that could be an interesting approach, and it would be under the research protocol. So for someone like this, that also could be interesting for your subject here with glycerol is not a protein, so that wouldn't show up. And even an antibody against glycerol is hard to imagine, but there it is. So we'll see.
Well, but I mean, she literally, I have pictures of her. When they stuck it under her skin, she got these big welts. I mean,
I don't
weird.
question it. I mean, just the question is, what do you do about it? And
Right.
you tried.
I didn't believe it was true. I thought she was just faking it, but that's just me. You know, I'm like, no, you just don't want to take insulin. But I didn't say that out loud. But she really, like, these big welts happened. I mean, it was weird. I don't know. Anyway, okay, let's talk about the next case.
If I can just
Oh, this one.
First of all,
Okay.
I agree with Lou that I think that patient would be a good candidate for the UCSF study, given the severe allergy, which is highly unusual. But the only other thing I wonder if you thought about, you probably already did, was diluting the insulin sufficiently so that you could maybe run it through a pump. Rather than having her get up at 4 a.m. You know, we do
Yes.
diluted insulin for our little babies, and we do pumps for little babies. And it seems like based on their dose of insulin, I mean, the question is if U500 is the only way to do that. And if
Well, you can put U500 in a pump.
Yeah, I mean,
Yes.
she'd, you know, have to reload it. I don't know if it would be stable all 3 days, or if she'd have to change the reservoir more frequently, possibly.
But we do it. So we have adults with that. So that could be done.
I have mentioned this to her. I think it's a great idea, but I can't explain this one in terms of her approach to life.
Right.
But her approach to life is because remember, she's quite overweight, and she has this like defensiveness against doctors. And so she's been misdiagnosed so much that she kind of doesn't want me to change it at the moment. If I could give her long-acting insulin, I think it would work, but I'm not so sure. I mean, she said no to a pump many times, but I think it's a really good idea. I haven't asked her in a couple of years, and maybe the Omnipod 5 or something would be great. So let me see. Thank you for that thought. I like it. I'll try again. Okay. This is a 31-year-old female who was diagnosed with type 1 diabetes. And somehow, I don't quite know all the story because it's so complicated, but she was diagnosed with type 1 as a form of GDM, and she was on insulin for pregnancy with her son. She wants to have another child. In the meantime, she got a family history, and her sister, brother, father, twin niece, and nephew, and another nephew all have diabetes. And this is kind of, I'm giving you this backward way, because they found out that the family had MODY when her brother's wife, carrying the twin niece and nephew, had an ultrasound in utero, and they found cystic kidneys in the fetus. And they worked up the whole family. And then they found that this was, and you guys use the fancy name, and I just say MODY5 because I can't say the fancy name. But they found out that this family has MODY5, and that's what they all have. Now, go to the next slide. She herself has renal cysts and some sort of uterine abnormality, even though she was able to carry her pregnancy to term. Unrelated, I think, to MODY5, her 2-year-old also has Klinefelter syndrome and MODY5. And her renal function is normal. And she wants to have another baby. So what exactly would you tell her, and how would you manage her?
Bro.
Right. I was gonna say, well, obviously she knows, like, it is a 50-50 chance. Like, there is, what I would not advise is that she do, additional fancy testing in terms of trying to pre-diagnose the baby, you know, because of the pregnancy risk, pregnancy loss risk from something like CVS or amniocentesis. Certainly, if there was a different reason, she could even see. I don't know that a genetic test would cover anyways, but you know, that would be a consideration. In terms of management, I think it's insulin. You know, HNF1 beta unfortunately doesn't have a precision therapeutic, and there's probably reason to believe that like an SGLT2 inhibitor or a GLP-1 receptor agonist would be a good idea, but obviously not in pregnancy. And so I think, you know, it's going to be insulin. And the good thing is, even though there is some endogenous insulin resistance, they respond very well usually to, you know, to exogenous insulin. So, but yeah, there's nothing, you know, certainly she could consider if she wanted to do IVF, if she were really concerned about another child, that would be obviously an expensive option, but potentially an option.
I mean, one of the few, you know, in GCK, there's been some interest in doing separation of the ova, so prenatal testing, and then also
cell-free fetal DNA.
Right. So so once you have the fetus, you could check, but you know, it doesn't help here very much. The other thing to be sure about is her serum magnesium. So we find that a lot of the HNF, so the two other names are RCAD, renal cysts and diabetes, and just HNF1 beta is MODY5. So the HNF1 beta gene is the one that also involves the cystic kidneys, and as Ro was saying, there's elements of infertility, there's bladder and other cystic and other reproductive issues with this syndrome, and a few other odds and ends, and one of them is hypomagnesemia from magnesium loss. And that can be a huge problem. And interestingly, we don't know, it doesn't need to be universal, but when it does happen, giving SGLT2s, you know, is at least an idea to reduce the magnesium loss. But I don't think there's like more than one or two, there's like anecdotal reports we're trying to put together. In fact, Ro and one of our fellows are exactly working on that to gather enough people to see in those folks with this syndrome and hypomagnesemia whether that is an effective therapy. We have some people where it's just, I mean, they're needing IV therapy like frequently. So I mean, I think she should consider surrogacy or egg donor if she doesn't want to have a 50% risk of a child having the same thing.
She seems to think that she can get her egg tested.
Well, you know, so I don't know of any outfit that's doing that with this gene in a way that's been published. So, I mean, theoretically, you can, you know, do PCR on the cloud around the egg and see whether that group has the 1 beta, but you know, it's expensive, and they, you know, they could be wrong. So and then what? I mean, obviously, it's not a fatal condition necessarily. It's not like, you know, Huntington's or something, but it's not fun.
No, and her magnesium is normal, by the way. I tested.
So it's interesting. I mean, we don't know why that is. Although some people seem to get worse as they get older. One of the people that one of our colleagues is seeing is like a late teenager or an early 20-something, and it has gotten worse as she's gotten older. So we're not sure why that is. It could be that the kidney damage is just worse, and it depends on the luck of the draw in terms of how bad your kidneys are.
Interesting. These are, they're so fascinating to me. I mean, I love what you guys do. If I had a whole other life, I'd be there with you in Chicago.
Well, you're doing this and everything else. But look, I think the other thing is we would love to have this family register in our study. There are other things we're doing. One of our other fellows is working on a sleep study, for example, in people with various sorts of known monogenic diabetes, because even when the blood sugars are well controlled, there seems to be an element of sleep disturbance, you know, that may not be all the way to obstructive sleep apnea, but still disturbed sleep and poor quality sleep and lots of awakenings and all sorts of things that should be recognized.
So much to learn. Okay, this is the last case. There's one more.
Well, I think there is at least one more.
Oh yeah, wait, this is her
Yeah.
tracing on, she takes insulin still, but she's on about 0.15 units per kilo per day. And this is what her tracing looks like. I love the way the nights are, but the days is obviously when you're supposed to be making insulin, and she's on a pump, but she does pretty darn well. But this is her tracing. They don't look like usual tracings, I don't think, when you see these patients, especially because of her nights. She's not on a hyperclosed loop system.
Yeah, no, I mean, this is probably as good as it gets.
Yeah, these are, I mean, my West Side patients are unbelievably adherent. She wants to have another baby. So she's, she needs to get even tighter control than this for a baby. I'm just pointing this out, but she will. I mean, these people do those things.
When given that there's several family members, they say, we would just love to have them enroll. And if she ever wants to talk to us about, just being in the study and what that means, and, is not a lot of effort on her part, but we would love to include them and get a sense of the various complications, exactly which mutation this is. And Ro, I mean, you can talk about that there's like multiple different kinds of mutations. So maybe you want to talk about that just for a second.
Yeah, well, what I was going to say is with the fellow that Lou referenced, we actually are close to publishing just our small cohort where we looked at a little more detail, like what age did all of the multi-organ features come on, and the amount of variability even between family members is just really incredible, which makes it hard to pin this down ever, right? Like it could be a child who has just the diabetes, but then it could be a child who actually has many of the multi-organ manifestations. So it's really difficult, unfortunately, in terms of the counseling. And then, the thing that I don't know if you know whether or not they've got an intragenic versus a deletion, but the only sort of genotype-phenotype correlation is that the kidney disease is actually a little better if it's a deletion, but then you're at risk of having like cognitive, neurocognitive effects. So a bit of a trade-off there, but yeah, I think the only clarity we gained is that there's not a lot of clarity, and I think it's the fourth most common cause, but it's a distant fourth. So I think that's the other piece of just it really is important to try to amass more and more people, try to get a handle on it better.
The family's really very sophisticated. This patient in particular is sort of in this grief phase because she didn't know she had this. She thought she had type 1. Then she has this baby who has Klinefelter's, and then she finds out he has this awful about her son having these 2 genetic problems. And she kind of wants to not have any of this, but I'll talk to her. I understand. I think that there's a lot to take in with what she's dealing with. And her dream was to have 2 kids. And I get that. And I want to support her in what she wants. So, all right, wait. Yeah, this is the last one, the next one. And this is one, Lou, you helped me with. And your help was so good that when I told him what you said, he left my practice and never came back.
Oh no, because I was about to tell you we're thinking about launching a study for just this thing. That's why I was hoping we would get to this case, so I can tell you about the study. But let's hear about the case and we'll see what happens.
He'll come back. He just got so scared. So this guy was a 26-year-old when I first saw him, PhD student from Mexico. He was first diagnosed with diabetes in 2016 when he was hospitalized with true DKA, and I've looked through his medical records. It wasn't, the lowest PhGK, but it was DKA, and he was told he had type 1. He was discharged on insulin, and he slowly weaned himself off of insulin in spite of the fact that all the medical notes from my colleagues at USC kept saying he had to be on insulin. But he weans himself off, and he came to see me because he said he thought he had a different sort of diabetes, which he in fact did. And at the time he came to me, I'm not sure when it was, this number of years ago, he had negative autoantibodies, a C-peptide of 0.9. He was lean at 21, a BMI of 21.2. his mother, brother, and cousin have diabetes at that point, undiagnosed, and subsequently diagnosed with what it really is. And then as I was seeing him, he was diagnosed with sensorineural hearing loss, which then pushed me in the direction of this mitochondrial diagnosis for diabetes. But he couldn't get tested because he couldn't pay for it. And he's a student on a scholarship from Mexico, and we couldn't get anything done with testing to see what kind of diabetes he had. But he was off of all insulin and his A1C was 6.2. So go to the next slide. Then he was seen at Kaiser, and Kaiser, for some reason, actually does gene testing. And he was diagnosed with a mutation in the MTTL1 gene, and I didn't know what that was, but Lou told me. And he was diagnosed actually because his mother was diagnosed with this gene mutation, and Kaiser did the gene testing on him to show that he and his mom had the same gene mutation. Then he moves up to San Francisco and is a postdoc in somebody's lab, and I don't see him. And then he comes back to see me, and he says he's in trouble. His A1C is 11.2. He said he tried every treatment to bring down his sugars, including insulin, which didn't work. And this guy doesn't like medicine of any sort. He feels that he got worsening diabetes because of the Moderna vaccine. And the sugars did start to go up about 2 weeks after he got the vaccine, and he did not have COVID. And he's a really avid runner. He's really fit, and he wants to treat his diabetes with lifestyle. And go to the next slide. And this is the last slide I have on him, which is showing what his sugars look like. And he's on 12 units of glargine twice a day, and he says insulin doesn't work. And I said, well, your insulin dose is not adequate. And he's convinced somehow that he can do lifestyle and make this all go away to where it was truly before COVID, where his blood sugars, his A1C was in the low sixes. But Lou taught me a lot about this, and I talked to him, and I tried to make him understand that this isn't something that does just go away. But he kind of didn't want to hear it. So I haven't seen him since. But if I do see him, I'll tell him we need to study him. But
right. Well, and so there's two, two interesting things have happened since the last time you and I spoke about this sort of thing. So one is I've made contact with this thing called the Mitochondrial Disease Network or something like that. And it's in part run by a group out of, I think, Philadelphia. But it's a network of mostly pediatric neurologists and some adult neurologists and the occasional nephrologist, very few endocrinologists. So they see things like Kern-Serre and Leber's hereditary optical neurodystrophy and, MRF. You remember MRF, of course, mitochondrial encephalopathy with ragged red fibers. And what we see, so that MTTK1 gene is, of course, the tRNA leucine of mitochondria. It's the T4T3 A to G mutation that we're so excited about. So these people don't do well, and what it really depends on is I think heteroplasmy, right? So we're talking about this all the time, and the idea is that from the bad luck from his mother's ova, he got a certain number of bad mitochondria, and by doing a urine sediment analysis, at least, if he's got magical thinking, I don't know how we can help him, but at least by doing a urine sediment DNA analysis of his mitochondrial DNA, we can get a ballpark idea of how substantial his damaged mitochondria are. And then we can go and sort of do, it's unfortunately a very extensive workup. He needs hearing checked, he needs a retina exam, he might need an echo, maybe a stress test, even though he's a runner. What often, if there is a imbalance in the number of mitochondria in his muscle, people get myopathy. And so then the diabetes is a race between bad beta cells and really sarcopenia at the end, which he doesn't have because he's a runner, but that's a thing. And then kidney disease is often focal segmental glomerulosclerosis. And that is sort of the other things cause that, but mitochondrial disease is most typically associated with that. And there's actually one paper in the literature on kidney transplant in people with the syndrome. But as I say, getting a sense of how, whether he has deafness, and it's typical high frequency deafness. So there's a lot to say about it. And there's 2 recent review articles, which I learned a lot from. One of them talks about other endocrine organs. So it's not just the beta cell, but you can have hypopara, you can have hypopituitarism, so the bad mitochondria can be anywhere. And you just have to keep it. It's even more extensive than I would have told you last year, now that I've been talking to these peds neuro people, and a very amazing person named Shanna McCormick, who's peds neuro endo at CHOP. And she and I gave a lecture just last week together where she focused on kids with mitochondrial disease who are primarily bad neuromuscular mitochondrial disease, who then get diabetes. And it turns out that kids with Kern-Serre and all these other terrible mitochondrial diseases, including Friedreich's ataxia, by the way, end up getting diabetes. Something like 30 to 40% of people with Friedreich's ataxia get mitochondrial diabetes. So I've learned a lot in a very short time. I've also learned that, if he wants to go back to Mexico, there's a group at Nuevo León University. There's a medical center there, and they have a group who I've just met again recently, who are very interested in monogenic diabetes. So I don't know if that, is any help, but we have contacts in Mexico. So for this young man, he needs, absolutely, you're always right, he needs more insulin. We need to do a more extensive workup, and he needs to buy into the fact that, that this is a genetic condition that is unusual, but we need to do more. So the final thing, is that there is a research study for intervention. So one of the guys that I met very recently is a guy named Fernando Scaglia, who is a pediatrician at Baylor, and he has a study on that's in what is it called? clinicaltrials.gov. And it's a study of citrulline, which a lot of runners might use anyway. It's an over-the-counter amino acid that's a precursor to arginine. People do grams a day. The dose is anywhere from like 2 to 6 grams, and apparently it doesn't kill you. And what it might do is bypass some of the defects caused by the bad mitochondria and help the happy mitochondria do their thing. So he's got a study where he's enrolled as of Friday, 10 individuals with MELAS. So he's not doing the diabetes part. He's doing neuromuscular function, help with seizure disorder, things like that. And so he's not even measuring diabetes. So what I'm proposing to him and a bunch of people this Friday is to have a meeting where we might try a real world experience of doing in-home treatment with citrulline in an EGM and other stuff. So that was, a 5-minute, like everything I know about MELAS with stuff that I'm still finding out. And if this guy would join our registry and would be interested, we're certainly interested in his whole family.
Well, it's even more interesting to me because I have MELAS twins in my practice. And one twin and they're now in their late 20s, I think, and mom still takes care of them. One twin is so neurologically impaired that, she's never developed beyond, young child level, and has seizures and everything else, and is in a wheelchair and things. And the other twin is got normal intelligence and function. And both of them have, type 1 like diabetes because they're on insulin and things. But the twin who functions, the MELAS twin, they're so sweet together. We love our MELAS twins. And I think they're also from Mexico. Is this more common in Mexico?
So nobody knows. I think, it seems to be the most number of papers per population is probably from Japan. And it's not clear if it's because there's just a couple of groups that are very interested, but some studies suggest that if you put together diabetes and deafness, you get a big hit rate, which could be like a significant double-digit percentage. But nobody knows. Hattersley, Andrew Hattersley says this is a lot more common than we think, and just nobody looks for it. Although now there are a growing number of panels are including MTTK1, and I just came across a lady this week who has a mutation in a different mitochondrial gene and has essentially a very similar MELAS syndrome. And as far as I can tell, there's 6 people reported in the world with that mutation.
Interesting. Well, it's interesting to me how different phenotypically the twins are.
Yeah.
But now I'm going to give them citrulline. Maybe that'll cure them.
Well, we would love to do it in protocol, but
I just
not
want to
everyone.
help them.
Not everyone can be enrolled. So I'll send you the link to the citrulline study, Dr. Scaglia's study. And, I think the beauty of this is if they didn't want to wait and you wanted to see off-label, it would be useful to do some sort of measurement, beforehand and after, and then we could, you could publish an anecdotal case report just to add to the literature.
Well, at this point in my life, I actually just care about helping the progress of all this, which is nice, but I really just want to help the patients. So
I get it.
I guess I've always felt that way, though. But
maybe there's a fellow who would like to write it up as a case report if you end up giving them citrulline.
No, I have the best fellow who's their doctor. They're very special. I've been following the MELAS twins for like 20 years since they were much younger. They're my girls. All right.
I'll say, I hope that the power of, since he would like to avoid, the sort of standard treatment, maybe this citrulline will draw him back in.
Yeah, I mean, I don't even know. So because it's over the counter, it's not obvious to me. So I have to work with Dr. Scaglia to figure out if we need an IND for an over the counter drug if we make it a clinical trial. But he already may have it. But so that wouldn't apply to you if you wanted to use basically an over-the-counter health food supplement in the amounts that seem to be okay. I mean, so it's interesting that it's out there.
But I guess my other question is, how much does this cost? Because these are people who are.
If you go, so I looked at a website this week to find out how much citrulline is. They sell it by the kilo.
My God.
So and then I did look, this is now, we all have our weirdness. So I did a deep dive into citrulline. It turns out it was named for watermelon because it's a predominant amino acid in watermelon, and people just purify it. So you can buy it in bulk. You can buy it in little tablets or pills to get your couple of grams a day. It seems to lower blood pressure because of its relationship to arginine. And as they say, so far as we know, it doesn't kill people. So, I think if I could send you some of the background information if you're interested.
Well,
it sounds like
when I see the twins next, I'll ask the mom and, the sister who's at least able to communicate with me. But they're amazing, this family. The family's under-resourced East LA. When a family member is disabled, they all, they give up their lives for the kid, and the mom's given up her life for these 2 kids. I really, really love them. So
well, it all, so it all comes together, but I'll go ahead and send you what I have about the study that Dr. Scaglia is doing, so you can just get a sense of what he's up to. It's all for him. It's all neurological and neuromuscular. It isn't diabetes, and he's got, he's published a little bit. He has a couple of review articles from a few years ago. This study, with an N of 9 so far, he has it's all, up to snuff. He has a DSMB, and they gave him a green light to continue. It's funded, so we can learn from that. Oh, and I see Lisa put it in the chat. I don't know if you can see the chat, but if you click on the citrulline study, you can it'll be in your browser. You'll be able to see it there. And also, Michael put the precision T1D information also in the chat.
This is great. See, you guys taught me so many things.
Well, you teach us, Dr. Peters, and we're just honored that you shared all this stuff with us. And if you do have other fellows who are interested or they have cases to present, you know, we will move heaven and earth to help out and either enroll people in our study, try to get their Spanish consent forms if that's what it takes. We are extremely interested in looking at populations that are otherwise underrepresented or scared or something, and see if we can't help them out.
Yeah.
What's the name? Just one last question. What's the name of the place that does the MODI testing that's inexpensive?
Well, us. I mean, if it's a research basis, we don't charge. It's part
I
of.
know, but what if it's just somebody who wants to go get it done? You told me there was someplace that was
Yeah,
cheap.
well, Invitae is, I think, the least expensive possibly right now. INVITAE. It's so
No.
inexpensive that they're actually in trouble financially. I read the other day. So, but they have like a capped out of pocket. You'll help me. Is it $250?
Yeah, it's $250 out of pocket. And we found that a lot of our families like Invitae. I believe GeneDx also has a $250 option, but their testing panel isn't as extensive as Invitae's panel.
Because I think Invitae includes them at least one or two mitochondrial genes.
Right.
Okay,
Right.
cool. No, the ones from East LA I'm sending to you guys because I think they'd be interesting because they're not the typical patient for your studies. And
yeah.
Well,
Well, anything that says Dr. Peters on it goes to the top of the queue.
Thank you.
No, and it really is. I mean, there's a huge equity issue in who actually gets to have a diagnosis. And so we would, please send.
Huge, because we tried to get it and then they're like, well, you got to go to pediatrics, and the pediatricians say no, and then we go to pediatric geneticists and they say no, and then we go to the Delta and they say we don't, unless it's for cancer, we won't do gene testing.
Yeah, so we say yes, and then we figure it out.
Yeah, there's one patient I was just going to pay the $250 myself because I need to know, but I'll send her to you guys because I just
send it to us. All we need is the tube is this big. If they can just spit into the tube, we can get enough saliva to figure it out.
No, I didn't know it was spit. I mean,
yeah, it's not even blood.
Because I can do blood too, because I still remember how to do it because I trained with the Days of the Giants.
Yeah, I don't come at anybody with a needle these days, but
oh, I do. You want me to put an IV?
I know you're a full service organization. I don't draw blood unless I don't even remember the last time. So but saliva works. I mean, we could probably do it from hair or an old tooth or something.
I'll get you saliva. I'm not going to pull their teeth. It's enough. I'm getting saliva.
All right. Thank you so much. And look, we can do this again when you have another few, or as I said, if any fellow has something interesting and you want them to, to present a case, we will set them up.
I love my fellows, but I think they're all becoming thyroid specialists.
Oh, don't say that. The heartbreak of hypothyroidism.
Yeah, it's really crushing.
Well,
guys.
No accounting for taste, right?
That's right. Thank
all
you.
Right.
Thank
you take care. Have a good rest of the week.
Bye.
Okay, you guys
Thank
too.
you.
Bye.